20% for those who did not.
Yes, I have the same.
Okay. Well, since we worked this out here and everything is okay, there we'll go to fried chicken.
Okay.
I got 80% for the fried chicken.
For those who ate?
Yes.
No, I didn't get that number.
Okay then. Well, then we'll have to do it over, recheck it and see something's wrong here.
All right.
Finally, we finished.
I didn't expect that this will take this amount of time. Imagine if we had a larger sample size. It would have taken forever.
We need to learn how to do this on the computer.
Yes, you know, I've heard of a computer program called EpiInfo that's really good for this sort of thing.
Yes, I used it during my MPH, but I haven't touched it since then. I'll need a refresher.
Rate differences and odds ratios are measures used to determine the association between exposures and illness. In the Kariba example, between each type of food and the occurrence of diarrheal illness. For example, the rate difference for those who ate and did not eat fried rice is the difference between the attack rate for those who ate fried rice, 34%, and the attack rate for those who did not, 29%, which equals a rate difference of 5%. In order to understand odds ratios, it is necessary to understand 2x2 tables. That is, a table with 2 rows and 2 columns. A 2x2 table is simply a way of laying out your data, with the exposure, yes or no, in rows, and the outcomes, usually the disease under investigation, yes or no, in columns. Let's use an example from the Kariba investigation to demonstrate. In the fried rice example, the exposure would be eating fried rice and the outcome would be getting ill. The number of persons who ate fried rice and got ill was 35, shown in block A. The number of persons who ate fried rice and did not get ill is 67, shown in block B. The number of persons who did not eat fried rice and got ill is 12, shown in block C. And the number of people who did not eat fried rice and did not get ill is 30, shown in block D. So the total number of exposed persons, that is, those who ate fried rice, was 102. And the total number who were not exposed, that is, who did not eat fried rice, was 42. The total number of persons who had the outcome, or got ill, was 47, and the total number who did not get ill was 97. You will also notice that the total number in this table is 144, though the sample size was 149. This is because only 144 people answered the questions about whether they ate fried rice and whether they got ill or not. Now, when we refer to odds, we're referring to the chance of an event happening to it not happening. For example, in Kariba, the odds of it snowing is more than 1,000,000 times to 1, simply because it's more than 1,000,000 times as likely not to snow in Kariba as it is to snow. The odds ratio is simply the ratio of 2 odds. It is defined as the odds of exposure amongst the cases divided by the odds of exposure among the controls. The cases are shown in the first column, and those with the exposure are in block A. The cases without the exposure are shown in block C. So the odds of exposure amongst the cases is A divided by C. The controls are shown in the second column, and those with the exposure are shown in block B. The controls without the exposure are shown in block D. So the odds of exposure amongst the controls is B divided by D. Let us use the Kariba fried rice example again. The odds of exposure, which in this example is eating fried rice, amongst those who got ill, is the number of persons who got ill and ate the fried rice, 35, divided by the number who got ill and did not eat the fried rice, 12. The odds of exposure, eating fried rice, amongst those who did not get ill is 67 divided by 30. This works out to be an odds ratio of 1.31. So what does this figure of 1.31 mean? It means that those who got ill were 1.31 times as likely to have eaten fried rice as those who did not get ill. If an exposure, such as eating fried rice for example, has an odds ratio of greater than 1, then it is considered a risk factor for the illness under investigation. If an exposure has an odds ratio of less than 1, then it is considered a protective factor. And if the odds ratio is equal to 1, then the exposure has no effect on the outcome. It is neither a risk nor a protective factor. Now, when rate differences and odds ratios are calculated, and an association is found between an exposure and an outcome, we must consider whether this association is real or due to chance. If a sample is small, it's very likely that the association could be due to chance. For example, if tablet X were to provide relief from headaches in 8 out of 10 people, we'd not be so likely to believe that this association is true. Because had we chosen a different 10 people, maybe only 3 out of 10 would have gotten relief. However, if we had a well-designed study of 10,000 people and 8,000 got relief, then we'd be much more likely to believe that tablet X worked. Because in such a large sample, it's unlikely that this association would have been due to chance. So, whenever we find associations in our studies, we must conduct significance tests to see if these associations are real or due to chance. You may have heard about p-values in connection with significance tests. P-value is a probability value. It is the probability that an association between an exposure and disease occurred by chance. In other words, it's not real. A p-value of less than or equal to 0.05 or 5% means that there is a 5% or less probability that the association was due to chance. So, we're almost sure that the association is real. In other words, it is statistically significant. If the p-value is greater than 0.05 or 5%, we say that since there is a greater than 5% probability that the association occurred by chance, we're not very sure that the association is real. Then we say that the association is not statistically significant. Remember though, that a statistically significant finding is not absolute confirmation that there is an association. It simply means that it is unlikely that the association occurred by chance.
Look at these rates. It looks as though the fried chicken was associated with this illness.
Yes, you know, originally Dr. Rogers and I felt as though it was the potato salad, but from these results, it really looks as though it's the fried chicken.
Yes, we've been at this for some hours now and it's late. I'll have my secretary type up a table for this first thing in the morning before the meeting with Dr. Rogers.
Okay.
Let us take a closer look at the analyses done by Dr. Wills and the nurse. Now that they have completed the analyses, they need to interpret the results and formulate a conclusion. Let us first look at the column of difference in percent or rate differences. In this column, we can see that the fried chicken was the food with the greatest attack rate difference between those who ate the food and those who did not, a difference of 25%. Fried rice, potato salad, and hamburger also had positive attack rate differences, but none as high as that for fried chicken. Hot dog and roti had negative rate differences, so that tells us that they were not associated with being ill, since the attack rate for those who did not eat the food was greater than for those who did. There was a 0 attack rate for oil down, so that tells us that the attack rate for those who ate the food and those who did not is the same. Let us now look at the odds ratios and p-values. Fried chicken had the greatest odds ratio, 3.81. This means that those who got ill were 3.81, nearly 4 times as likely to have eaten fried chicken as those who were not ill. Since the p-value is less than 0.05, 0.004, we believe the association is real and statistically significant. While the odds ratio for fried rice, potato salad, and hamburger are all greater than 1, the p-values for these associations are all greater than 0.05, so the associations are not statistically significant. And we do not believe these associations are real. We think that it is likely that they could have occurred due to chance. The odds ratio for hot dog and roti are both less than 1. But do we think these foods are protective against the illness? No, because the p-values are greater than 0.05. So the associations are not statistically significant. And we do not believe the associations are real. We think they could have occurred by chance. But certainly, there's no evidence to suggest that these foods are associated with being ill. The odds ratio for oil down is 1. So this means that there's no association between eating oil down and getting ill. It is neither a protective factor nor a risk factor. Finally, you notice that odds ratios, p-values, and rate differences were not calculated for corn soup. This is because it could not be done, since no one who ate it got ill, and cases are needed to calculate rate differences and odds ratios. However, since no one who ate the corn soup got ill, we can surmise that it is not associated with illness. Sometimes, even if we cannot calculate odds ratios and rate differences, we can still interpret the data. Let's go back to the Kariba team and see how they're using their results to formulate their conclusion.
Based on the information we have, the clinical presentation being diarrhea, abdominal cramps, fever, vomiting, an incubation period of between 8 and 24 hours, a significant attack rate for only fried chicken, and the lab reports came in this morning confirming the serotype for the remaining 5 samples and Mr. Hall's sample as Salmonella enteritidis. I would say that with the evidence we now have, that we could now conclude that it was Salmonella enteritidis in the fried chicken that was the cause of the outbreak that occurred between the 11th and the 13th of June.
The medical officer of health formulated a conclusion based on a comparison of his hypothesis to the facts, his analysis results, and laboratory test results. However, if he had not been able to formulate a conclusion, he would have had to revise his hypothesis, retest it with new data, and reevaluate the results. The next step is to put control measures in place. Usually, these measures are to control the current outbreak or to prevent similar outbreaks in the future. Control and prevention measures should be implemented as soon as possible and may be done very early in the investigation.
This outbreak is over, but how can we prevent another outbreak of its kind from happening?
I think public health education is the best way to go.
I agree with you. I think we need at this point to invite the public health education specialists to a meeting, and we need to get certain messages out to the public. We need for the public and food handlers to know that hand washing is essential, that meats need to be cooked thoroughly, that meats need to be stored properly prior to and after cooking, and that different chopping boards be used for vegetables and meats to prevent cross-contamination.
I think that we need to get these messages out as quickly as possible. We are already into the carnival season and a lot of people will be eating out.
For a short-term measure, we can use radio and short TV spots. And in the longer term, posters and videos in health centers, etc. can be used.
Good points. I think we need to.
Now, the final step in this outbreak investigation is to write and disseminate a report. A formal written report and an oral briefing should be done for the ministry, and perhaps a release should be done for the media. The points to be discussed in the written report are: introduction, which should outline the situation surrounding the outbreak and the reason for the investigation. In the Kariba example, information about the first alert from Kariba General Hospital, etc. Methods, to describe what was done in the investigation and how. Again, in the Kariba example, one would need to say that telephone interviews were done on 149 records, etc. Results, to say what was found. In the Kariba investigation, which foods were associated with illness and which were not. Discussion and conclusion, to interpret the findings and make a conclusion, such as the only food that was found to be significantly associated with illness was fried chicken. And recommendations, to suggest what should be done to control the problem and prevent it from reoccurring in the future.
Oh, come in. Oh, the report is completed?
Yes.
I need you to ensure that a copy of the report gets to every member of the investigating team, and I'd like you to arrange a debriefing meeting.
Good afternoon, everybody. Thank you all for coming. Let me introduce the panel by starting with our permanent secretary, Mr. Rollins, lab technologist, Mr. Wilshire, communication specialist, Ms. Phillip, district medical officer, Dr. Wills, chief medical officer, Dr. Campbell, public health inspector, Mr. Lawrence, and our 3 surveillance nurses, starting with Nurse Francis, Nurse Burrows, and Nurse George. I am Nurse Charles, and I want to introduce our medical officer of health, Dr. Rogers. I'm going to hand over the meeting to Dr. Rogers now. Thank you.
Okay, good afternoon. I want to thank each and every one of you for taking time off from your busy schedules to attend this evening's meeting, especially you, Mr. Permanent Secretary. Now, this evening we're here to present a report into the investigation on the outbreak at the Kariba Fun Fete. Now, this nurse.
Yes, doctor?
Look, the report on the outbreak is in today's paper.
Oh, yes, I saw it. It's really very good.
You know, it's a good thing we got the ministry's communication specialist to write something. This outbreak was big news and something would have gotten into the paper. At least this way, what's in the paper is what the ministry wanted to say.
Now the Kariba Fun Fete outbreak investigation is complete. The 10 steps have been done. These steps are: 1. Confirm that an outbreak exists. 2. Verify the diagnosis. 3. Make a quick assessment of the patients. 4. Relate the cases in terms of person, place, and time. 5. Formulate a precise hypothesis. 6. Plan and conduct a detailed epidemiological investigation. 7. Analyze the data. 8. Formulate a conclusion. 9. Put control measures in place. And 10. Write a clear and concise report. Remember, it is not necessary to do the steps sequentially. In fact, control measures are often initiated very early in investigations. Also, an outbreak investigation is not a one-man job. It is a team effort. And most importantly, an outbreak is a public health emergency. It is not business as usual. Well, We hope you've enjoyed this video series and appreciate and understand the steps involved in investigating and managing an outbreak. Good luck in your future outbreak investigations.